Good morning and good afternoon, everybody. This is Rich Killowald with the American Cancer Society. Welcome back to the final of the 3 sessions of the COVID-19 and Cancer Echo series. So glad you could make it today. A couple quick introductions before we kick things off. Again, use the Q&A portal throughout today's session to submit your questions, because our expert faculty will be answering your questions live. If you're joining us on a desktop or laptop computer, most likely the question and answer button is at the bottom of your Zoom window in the black bar. It just says Q&A. If you're on a mobile or a tablet, maybe touch your screen. You might see it along the bottom or the top, depending on how you're joining us today. Reminder, all Zooms do take place on the Zoom platform. All echoes take place on the Zoom platform. You can review Zoom's privacy policy at zoom.us/privacy. And a quick reminder that this echo will be recorded today. And you may have received an email yesterday with the recordings, links to recordings and slides and resources from the previous 2 echo sessions as well. So thank you for that. And with that, let me hand it over to Dr. Laura Makaroff, Senior Vice President of Prevention and Early Detection at the American Cancer Society, our facilitator for today's call. Laura?
Great. Thanks so much, Rich. And thanks everybody for joining us today. We're looking forward to this 3rd session of our COVID-19 and Cancer Echo series. We've been so pleased to be doing these sessions in partnership with the National Comprehensive Cancer Network. And we're joined by several of their experts today as well. Before we get started, let me just go through the agenda. This is very similar to the last 2 sessions if you've joined us. But for anybody who's new, let me just orient you to the way that the hour will flow. So I'll go through some introductions of our faculty members. We'll have a didactic presentation by Dr. Tom Varghese about different issues related to COVID and cancer, including a small look at COVID and cancer screening. And then we'll open it up to the Q&A session, which is really the meat and the great part of today. So we have a lot of your questions that you've submitted from the pre-registration process, but feel free to submit questions through the Q&A portal that Rich mentioned as well. We'll try to get to as many of those today as we can. So before I turn it over to our didactic, let me just go through some introductions so we know who everybody is here in our call today. So first, we have Dr. Larry Schulman, who's Professor of Medicine, Deputy Director for Clinical Services, and the Director for at the Center for Global Cancer Medicine at Aberson Cancer Center at the University of Pennsylvania. He's also currently Chair of the Commission on Cancer and serves on the National Cancer Policy Forum of the National Academy. He is also the former Chair of the American Society of Clinical Oncology Quality of Care Committee and the Commission on Cancer's Quality Integration Committee. Next, we have Dr. F. Mark Stewart, who is Medical Director and Senior Vice President at the Seattle Cancer Care Alliance. In this position, he oversees all of their outpatient clinics. His research over the past decade has focused on the optimal use of advanced practice providers, drug safety in oncology, and clinical productivity. In addition to serving on the Board of Directors for the National Comprehensive Cancer Network, Dr. Stewart also is co-chair of the Best Practices Committee that NCCN leads. In this role, he helped launch a patient safety campaign focused on the administration of the chemotherapy drug vincristine recently. And last, but certainly not least, we have Dr. Tom Varghese, who's Executive Medical Director and Chief Value Officer at the Huntsman Cancer Institute at the University of Utah. In addition to those roles, he's also head of the section of General Thoracic Surgery and Program Director of the Cardiothoracic Surgery Fellowship and an Associate Professor in the Department of Surgery at the University of Utah. He also holds leadership positions in the Society of Thoracic Surgeons, the Thoracic Surgery Directors Association, the American College of Surgeons, the Society of University Surgeons, and the National Comprehensive Cancer Network, or NCCN. So thank you again for joining us today. We look forward to the session together and to learning together. With that, I'll hand it over to you, Tom.
Thanks so much, Laura, and thank you everybody for this honor of leading this final session. As Laura correctly pointed out, I serve in these privileged roles over here at the University of Utah, specifically at the Huntsman Cancer Institute. We'll go to the next slide, which should be our title slide. Really the talk today is about, okay, the pandemic's going on. We're kind of in this space where we don't know exactly how much longer is this going to last, or is COVID just going to be part and parcel of our environment for years ahead of time? And how do we go about re-engaging patients? Next slide. It's something that it's sometimes nice to really think about what the environment of the world was like before the pandemic. Now, this seems like it was years ago. I promise you this was early January. So on January 8th, This was one of the lead articles in the New York Times, and this was on the front homepage of CNN. And that was that the cancer death rate saw the sharpest one-year drop ever. And that we had really talked about making significant progress in survival rates and decreasing cancer death rates and improving treatment options for all of our cancer patients. And so if we go to the next slide, this was all based on this press publication that comes out every single year by the American Cancer Society. So these are the cancer facts and figures. This particular picture shows all the different states in the United States, and the numbers are the new cancer patients that are diagnosed every single year. But the more important figures are the following slide. So the next slide, we can see this is over time, the death rates in males over time from 1930 to 2017. You can see that that top curve is the highest mortality, obviously, is in lung cancer, causing the highest number of deaths every single year in the United States. And you can see that there was this huge peak, and then now you can see the curve is going down. But for all the cancers, you can see the curves are starting to go down. Next slide. The next slide really shows what the cancer death rates are for women. And same type of thing. You see those trends, that all the curves started going up, and then we made tremendous progress overall as a nation in terms of dropping those death rates. Next slide really goes down to the specifics of the report. And this is the reason why all the press release and all and the media reports came out. So cancer death rate declined by almost 30% from 1991 to 2017, with the largest ever single year drop. Most of that single year drop, the majority of that, again, not surprising if you have the highest death rates coming from lung cancer, and if you do significant improvement in that, it's going to relate to a significant drop. You can see specifically in lung cancer, the death rates have dropped by about 50% and about 30% in women, and the annual reductions was 4 to 5% per year in 2013. 2013 is not surprising that it started there. That was 2013 was when the Nelson trial, the lung cancer screening trials, really proved the mortality difference in high-risk patient population, heavy smokers, and utilizing cancer screening in that patient population. And there was some slowing, but still progress was being made. This is the lay of the land in January of this year. Next slide. And so this was another follow-up. The Nelson trial in 2013 was published for the United States. In February, this was published in the New England Journal of Medicine. That is, they took the same Nelson trial criteria and went to Europe. And this was mainly done in the Netherlands and Belgium. Minimum follow-up about 10 years. And you can see the conclusion right there. Lung cancer mortality is significantly lower among those who underwent volume CT screening than among those who didn't undergo screening, showing the positive benefits of screening in a high-risk patient population that could potentially develop lung cancer. Next slide. And so when we're talking about all of this, one of the things we realize, even though we're talking in the setting of a pandemic, in cancer, the public health model also is applicable. That is, the public health model, this was advocated by the World Health Organization, by the Centers of Disease Control. That is, you define a problem, you identify risk and protective factors, start developing, testing, screening, preventive strategies. Obviously, the biggest thing for lung cancer has been smoking cessation over the decades. And then you assure widespread adoption through education efforts, through making health policy, through advocacy efforts. You make sure that there's widespread adoption. Next click. When we go to the next click, you can see as a result of this public health model in every single cancer entity, we've made significant improvements in 5-year cancer survival rates. So to orient you on this picture, on the left-hand side, the pink dots are in 1970 and 1977, and then the black dots on the right-hand screen are from 2007 to 2013. You can see in every single cancer, even the worst outcome ones, such as pancreatic and liver cancer, we have made improvements in terms of 5-year cancer survival rates in the United States. Next click. And again, these of all the different efforts that have done in the world of cancer: screening efforts, reduction in smoking, enrollment in clinical trials, patient advocacy efforts, community awareness, public policy. Every single thing that you can think of is all reflective of the robust success of the public health model in the world of cancer. Next slide. So as all of you are connecting around the country today, all of you are leaders. And we know that as leaders, there's a lot of different definitions. There's tons of books out there, lots of seminars. We know that it's the action of leading a group, and or the position itself can be defined as leadership. Next slide. The process of influencing people towards accomplishing a goal. Next slide, please. And this is a definition, one of my favorites from John Maxwell: a leader is one who knows the way, goes the way, and shows the way. And it's kind of interesting that in this pandemic, this has been the hardest thing to do for all of us, because we don't know what the way is forward. We're all learning from each other, and we're trying to figure out how to do it with the information we know at hand. How do we lead people or lead organizations in making sure that we achieve the best outcomes for our patients as well as our organizations as well? Next slide. Every leader knows that at some point in their career, or often multiple times in their career, they're going to face a crisis. And this is a definition where it's a time of great danger, difficulty, or confusion, when problems must be solved or important decisions must be made. And that's a key thing. And next click. That it's really that twofold type of thing. And of course, we're now in day 55 since the World Health Organization declared COVID-19 as a pandemic. And yesterday's numbers, there's been 3.6 million confirmed cases worldwide, 1.2 million in the United States. There's been 250,000 deaths from the disease, around 60,000 deaths here in the United States, 19,000 deaths coming just from New York City. This has been devastating in terms of its toll on the population and worldwide in terms of both morbidity and mortality as well. Next slide. So this is a remarkable article that was just recently published in JAMA, really talking about the reproduction number, or the impact of a viral infection. And there's a lot of different terms that are thrown around: reproduction number. You hear things like R0, that is designated by the R0 number, but it's really more about the potential or the infectivity rate. And you can see just the difference between if the reproduction number is 1 versus if the reproduction number is 4, just on your screen. You can see the devastating way that this disease can spread. And I think one of the sobering things that all of us have been dealing with around the world is the success rate of this virus to really spread. And I think that they're recognizing that a lot of patients or individuals could be asymptomatic carriers. And so it's not like other diseases where once you're infected, you become sick right away. And it's something that we have to kind of keep in mind as well as we kind of navigate the world forward. Next slide, please. This is the reason why lockdowns or shutdowns or all these different efforts were done across the world. And it really, it comes from the CDC. It's when you think about the number of cases, and going back to the reproduction numbers, if you don't do protective measures such as social distancing or wearing a mask or restricting your movement, if you don't do that, what ends up happening is you could potentially overwhelm your healthcare system. And the reason we're doing all these mitigation efforts is to try to bring down the rate of infection low enough that when patients are infected, our health systems have the capacity to take care of them. And it's a sobering reminder that mitigation efforts by itself will only lead to kind of controlled rates, but it's not going to be by itself leading to eradication of the disease. Eradication of the disease is going to be brought about by, honestly, the development of the vaccine. That's the way that you're going to be finally able to get rid of this disease. And I think it's something to kind of remember as we've gone through lockdowns and several states are now starting to open up business, that the reason we did all this is to make sure that your healthcare system has the capacity to take care of the sickest amongst us, and make sure that we have the abilities to do that in a safe environment as well. Next slide, please. This is a graph from that same JAMA article. This is from Wuhan, where the start of all this infection came. And so what they were showing you is, again, in early January, without strong interventions, that was the reproductive number. That was the number of patients that were people getting infected. Then they started with stopping migration, but no strong interventions at that point. No universal masking, no social distancing. Kind of a little bit of a bit, but then again, it starts going back up. Then you can see the next thing is they locked down the system, and then they suspended traffic and started instituting home quarantine. And in China, they were so strict that they started actually embedding in video cameras in people's homes and apartment complexes, really to keep an eye on, are people actually leaving the home at all? And you can start seeing the plummeting of the reproduction number. And now you start centralizing the quarantine and the treatment improving. And then you can see that last phase that Wuhan did was the universal symptoms survey. Around the world, of varying different degrees, these type of efforts was what was instituted as a result of the lockdown. You can see this was the most stringent, but this is what they needed to do because that was the epicenter of the infection, which started it all. And they needed to make sure that they could try to get things under control as well. Next slide, please. So one of the things that all of us are really worried about is what is the impact of COVID-19 and the pandemic on our cancer patient population. So this is a report that just came out on May 1st, and this is the Epic Health Research Network, where what they did is they started looking at the number of hospital systems across the country who actually have Epic as their electronic health records, and the people doing preventive cancer screenings. We all know that one of the lockdown measures, the first things that went away was the vast majority of us stopped doing our preventive cancer screenings, again, to reassess to see what the healthcare system capacity was and to make sure we were providing that a safe environment. So this included 2.7 million patients as of April 25th. And then what they noticed, their findings was screening appointments in March of 2020 decreased by 86 to 94% as compared to a similar period of time in looking over the years from 2017 to 2020. And then we'll show you a couple of figures from this paper as well. Next slide. So the figures basically say is, so this is what they were looking from 2017 to 2020, the actual number of breast cancer screenings, colon cancer screenings, and cervical cancer screenings. This again is across those various different hospital systems across the United States. And you can easily see when you look at the far right-hand part of your screen, you can see in 2020, there's a massive plummeting of cancer screenings. This is not surprising to any of us because this is kind of what all of our health systems did to restock and make sure we had the healthcare capacity as well. Next slide. Now you can see the perspective as compared to different years ahead. So the bold line, the bold pink, the bold purple, the bold green, that's the year 2020. And you can see that in 2020, everything's plummeting down as compared to the years 2017, 2018, and 2019, where you can see that screening the rates are pretty consistent year round. And I think that this is kind of one of the realities we have to deal with. There are a number of patients out there that have undiagnosed cancers who haven't gotten their screening. How do we start engaging them when many of those patients are scared to even come in for their screening mammography or their screening colonoscopy or their pap smear? How do we engage with that as well? So next slide, we're going to be talking about some of the principles in leadership during a crisis. And what I want to just to focus on is to remember 2 core principles and 3 behaviors that you can expect as leaders when you're dealing with any type of crisis as well. Next slide. And these are the 5 total as well. The purple are the 2 core principles. That is, the well-informed leader or the well-informed organization needs to make well-informed decisions. And how do you go about trying to collect that information to do that? And we're going to be talking briefly about the last core principle, which is teaming, as one of the slides. And then the 3 behaviors you just have to remember that kind of is complementary to these 2 core principles is you never forget the lives that you impact. Every single metric that you're looking at represents a patient life. Every metric, a death rate is a patient who tragically has died, and that impact on that family and the community. Yeah, I'll go first. Every leader knows that anytime there's a hard decision you have to make, whether it's restricted access or universal masking or a pay cut, as we're dealing with financial instability, that ideally the leader should go first. And human beings are human beings. We know you're going to expect the whole gamut emotional toil, and you have to kind of expect and anticipate those emotional reactions and have plans to mitigate that as well. Next slide. So this is, I'm going to just take you through a snapshot of the journey of our center here at the Huntsman Cancer Institute. This is kind of, we have beautiful mountains, and this is kind of the University of Utah campus. Next slide. And then where we practice is the Huntsman Cancer Hospital. So we're part of a matrix organization. We have a freestanding cancer hospital. It's 100 beds. 84 acute care, 16 ICU, 8 ORs, 6 endoscopy suites. Next click. And we're very fortunate that we're part of a hardwired network. We're an NCCN Cancer Center. We're an NCI Comprehensive Cancer Center. We're also accredited by the Commission of Cancer, just to name a few. And the reason why this becomes important is we have the ability to have this rich network within our organization as well as nationwide as well. Next slide, please. But one of the things you have to remember as part of a matrix organization is there are a lot of different sites of clinical care. And next click. When we tabulated it up, we actually have 117 clinical locations of care. And our center is not nearly as massive as Dr. Schulman's center over in Philadelphia or Dr. Stewart's center over in Seattle. But this is just kind of just a reflection, the sobering reality that every single clinic or every single diagnostic testing center is a potential site of clinical care. And whatever strategy you have to come up with, you have to keep that in mind in terms of how and where you engage with patients during and after this pandemic as well. Next slide, please. So the well-informed leader needs to make well-informed decisions. And so what you need to do is you need to make sure you have the right team members around, you're tracking the right metrics, and what are your right communication strategies as you try to navigate this world during and after the pandemic as well. Next slide, please. And so this is kind of just to show you that this is kind of the command center that we've assembled here at the Huntsman Cancer Center. Now, this normal leadership group is probably about a third of this size in normal times, where a third of the size, we probably have weekly meetings. And then it serves as the bridge with the rest of the organization. I also report to the chief medical officer and the chief quality officer throughout our health system. And I would have maybe monthly meetings with them. That's the world that was pre-pandemic. During the pandemic, one of the first things we did is we got additional right team members involved. You can see that we got representation from the supply chain, representation from infection control, much larger group. And then we increased the frequency of the meetings. So at the beginning of this pandemic, in mid-March, this team was meeting twice a day. And I was having daily meetings with the rest of the university leadership. Now that we've got things under a little bit better control, we're able to space that out. But that's kind of one of the first things you have to think about is, do you have the right people around to make sure that not only do they represent the different disciplines, but they're all empowered to make decisions that can help you in your strategies as well. And so I think that's the first thing that we would really advocate for, to be that well-informed leader, to make the well-informed decisions. You got to have the right team around you as well. Next slide. These are some of the metrics that I look. So this is the metrics. These are the metrics I look at every single morning. What are the number of Utahns who have tested positive? How many inpatients do we have? How many people are in the ICU, and so forth as well. Utah has been incredibly strange as compared to the rest of the country, and we're not quite sure why that is. We've actually tested very, very broadly. Right now in our state, anybody can get a test, a nasopharyngeal swab, without even a physician's order. We have 5 drive-by clinics. If they want to get a test, they can come in. We've been very fortunate. We have one of the largest testing laboratories in the country. So as of this morning, we've done 124,600 tests. We've only had 5,000 COVID patients, and we've only had 441 hospitalizations with 50 deaths. And so we're not quite sure why that is. Is it because we have a younger demographic? Is it because people here in the Utah and the Intermountain West are much more active as compared to other people? We're not quite sure. So we have thousands of COVID patients and thousands of people that have recovered. It's just that they haven't come into the hospital. Or is it because we're just so early as compared to Seattle, Philadelphia, and our surge is still coming? And so it's something that we have to keep in. So the only way that you can plan for anything is you need to have the metrics. And so again, these are just examples of metrics that we look at every single day as well. And we work in close partnership with the Utah Department of Health. Next slide, please. So here's a couple different, this is a great article that came out in the New York Times about 5 ways to follow the coronavirus for any metro area. Next click, please. And so really the 2 of the metrics they talk about is the big picture. How many new cases are happening? How many deaths do you have in the state? And you can see the number 2 is where the outbreak is worst right now. And you can see Salt Lake City, where I'm at, where in terms of cumulative cases, we're ranked 120th. and cumulative deaths, we're ranked 323rd. Now, obviously, this is a moving number, but it's something that you can keep an eye on. And next click, the three other ways are predictive models about where outbreaks can come next, where there may be good news, where you can see the downslope of cases and decreasing number of cases, and potential prediction of not only current places that are hit hardest, but as well. And so the metrics that I showed you in the previous slide, this article can also give you kind of that framework of how you can try to follow coronavirus in your center as well as across the nation as well. Next slide, please. So this is what we came up with kind of as a planning. So we're looking at the metrics, and then we came up with this color scheme we call PACE. So green is when there's normal operations, no pandemic, nothing at all. Red is emergency, everything's all shut down. And then we have the yellow and orange colors in between. And whatever you end up planning at your current center, it's good to have these type of definitions in play. And then once you do this, you can start doing the planning. So green is normal operations, yellow is a busy day, but we can kind of make do. And then the orange and red, we have to start making some plans to really accommodate for the resources as well. Next slide, we can kind of show you an example of different things that you have to accommodate. In each of those different categories, there's what we call the 5 S's. You're looking at space, what stuff or resources you need, the staff, the manpower, the security. Security really meaning to provide the safe environment, restricting access or visitor policies, and anything else special, social work, case management, EBS, environmental services as well. Next slide, you can see here's an example draft of our critical care, really just tabulating in green normal operations throughout the system. We have 80 ICU, not just Huntsman, but also the university system. And then in red, where we call the crisis standards of care, where the state and the governor declares an emergency because of the number of COVID patients. This is kind of the thing. Now, we were fortunate because we had plans like this because the University of Utah kind of sits in the middle of earthquake country, and we have wildfires in this area. And so we were able to repurpose a lot of the plans we had for earthquakes and wildfires and directly apply it over to COVID as well. And I suspect that across the country, different environments have different things. You may have tornado plans or hurricane plans, and those are good natural areas where you can kind of look and start restocking and calibrating your teams to deal with the current pandemic as well. Next slide, please. So on March 16th, we suspended operations in terms of surgical procedures. We reclassified them as emergent, urgent, and time sensitive. And the time sensitive were, this is really where most of the cancer operations, where you couldn't delay it beyond July 15th. So this is what we did first. We shut everything down for 2 weeks, and then we started re-engaging and started moving forward. And again, going back to the flattening of the curve concept, this is what we needed to do to reassess and see what resources we had as well. Next slide, please. And so the reason, again, for these OR preparations, we want to create capacity in the hospital, make sure we had the proper infection controls, and also the ability to flex our workforce, to redistribute people, to say that if they're needed in the ICU as well. We, again, had the luxury of time. Dr. Stewart and Dr. Schulman are probably going to echo in about they didn't really have the luxury of time. They had to do all this in real time because their cities were hit right away. But one of the benefits of being in this interconnected world is we were able to learn the lessons from them and kind of apply it to our environment as well. And so this is kind of the things that you have to think about is before you start engaging patients, you have to create that safe environment as well. Next slide, please. And so then we did a communication strategy. This is just a snapshot to say we came up with what are called webcasts. So our leadership team every single day would do these webcasts, kind of going through the metrics, explaining to people why we were enacting different policies. This is on an internal website, but this allowed people to really understand the why. One of the biggest things what you find in communication is not only do you need to have the messaging, you actually have to do a lot of rumor control as well. Because you can imagine everybody's hungry for information and you start having these rumors coming in, and you need some central mechanism by which you can make sure that the proper communication is being distributed each and every single day as well. Next slide, please. So there are 3 issues when we're dealing with infection and cancer. And next click. And the 3 issues really is this impact of delay in treatment versus a harm in infection when you're taking care of an immunocompromised patient, the impact of social distancing and on the care delivery, as well as resources as well. Next slide, please. So as part of the NCCN, one of the benefits that we had is that we had set up weekly conference calls with what's called the Best Practices Committee, where a number of us, Mark and Larry and I are on this committee, were able to do these weekly conference calls. And the purpose of that was really to find out what different centers were doing, but also at the same time to distribute out and share those best practices. Next slide. And then we created this kind of public website within the NCCN website that anybody had access to. And you can find a lot of the policies and procedures that the NCCN centers enacted as a result of COVID-19 pandemic. And next slide, please. So the delay in treatment versus harm and infection, we know that most cancer patients are elderly. They have a lot of comorbidities and a lot of big issues surrounding the immunocompromised state. Next slide. I believe that the next slide, a couple slides, Larry had kind of shown in last week's webinar in terms of the impact of infection. This is again from China, 2007 patients from 575 hospitals. Next click. And really what it's showing is, and you can go to the next click as well, is that if you have a patient who's undergoing cancer treatment, but even if they have a history of cancer, they're cancer survivors, and they get COVID infection, significant increase in risk of morbidity and mortality for that patient population. And that's why I think it behooves all of us to make sure that we create that safe environment so we can take care of the patients. And patients are not stupid. They know this information. So it's also part of the thing is trying to engage patients to make sure that they get timely care, understanding that they're also scared about the impact of developing an infection during cancer treatment or otherwise as well. Next slide, please. Traditional oncology care, next click. This is what it was pre-pandemic. Lots of family members, patient advocates. As a thoracic surgeon, my new patient visits on average about 1 hour. You know, you talk to them about risks and benefits of surgery, you sign them up, but then you're talking about, are they eligible for any clinical trials? Oftentimes there may be multiple clinic visits, there's hospital admissions, lots of diagnostic. This is what our world was before the pandemic. And the pandemic has affected every single aspect of this traditional oncology care. Next slide, please. And so that in the new normal includes things like all the NCCN cancer centers across the country have temperature screenings of every individual coming into the center, asking them for, do they have any symptoms, a zero visitor policy, or really severe restrictions of the visitors that are allowed, decreasing the number of human beings walking into your buildings, and a universal masking policy. There's also universal testing now in various different degrees. We had mentioned in prior webinars that before any elective surgical case, they're all tested to see whether they have COVID or not, because the impact of developing COVID in the postoperative state is so massive that we can't take that chance. And now there are centers talking about, should they be routinely testing for patients before they start any type of chemotherapy infusion as well. Next slide really shows you, this is on that NCCN website. This is an example of our zero visitor policy, just really going through with a couple exceptions for end-of-life care and one for very unusual circumstances, but really explaining to the public at large what our zero visitor policy is as well. Next slide, please. Oncology care traditionally consumes a ton of resources, and we know that. There's a lot of equipment, there's complex interventions. Next slide. And so it's kind of one of those things that, you know, this is what, from our center about flattening the curve, what we've done to really do the capacity, but it's something you have to really keep in mind. Traditional oncology care is going to consume resources. So as you start re-engaging your patients, you have to really keep a close eye on those resources. How many masks do you have? You know, do you have enough temperature probes to do the temperature scanning? You have to really think about that granular level. OR equipment, sterilization. You really have to keep all those things in mind as well. Next slide, please. So this is kind of another model that not just flattening the curve, but you have to increase capacity. That is that, you know, you flatten the curve, that's great, but you have to increase the capacity. You have to anticipate you may have mini surges or rebounds in infection. You have to plan for that as you go forward as well. Next slide, please. And so the new normal is you plan and prepare for large surges, and then you're also balancing this restorative care. But the reality may be you may need to go back and forth. You know, we talked about the green and the red and the yellow and the orange, but you may need to create an environment where you may need to be seamlessly going back and forth between the different categories. And I think this next click was a tweet that just came out this weekend, which really is sobering. The end of the stay-at-home orders doesn't mean the pandemic is over. It just means that we have room in the ICU for you if you get sick. It's a sobering reality check in terms of what the environment is. The infection's still there. There's still community spread. And so you can imagine if people go out and don't use the protective measures, you're going to have outbreaks in your community, and you have to plan for that as well. Next slide, please. So this is the path forward. It's always a balance. You always have to check a bed availability. You have to make sure you have enough PPE. Medications, there's a propofol shortage going around the country right now. There's a lot of ICUs heavily consuming propofol, and something that all of us around the country are worried about. But you have to create that safe environment, and it's safety for all, not just patients, your team members, your healthcare workers. That's the goal, and you have to make sure that you built this environment to be able to tackle that as well. Next slide, please. And so these are the five principles we talked about. Next slide. For anybody who's interested, this is a great book. Teaming is a concept brought forward by the brilliant Harvard professor, Dr. Amy Edmondson. Next slide, next click. And really talking about, it's not just the artificial structure of teams, but when the need arises, you may need to assemble or connect with people that you normally don't work with. And it's a dynamic effort. Next click. And it's something that you have to do. It's teamwork on the fly. And it's something that not just with the pandemic, with any type of crises or any type of issues, you just have to really account for that as well. Next slide. And so for those who are interested, I recently wrote a blog post about a lot of these decision-making times of crisis. There's a click down there, and we'll make sure that people have access to that. But it's really just outlining all the different steps that I just talked about as well. Next slide. I believe that's my last slide. And then we'll open it up to questions. Thank you, everybody.
Great, thanks so much, Tom. We've got couple questions in our Q&A, and we have some pre-submitted questions too. I'll give you a chance to breathe for a second, but thank you for that. And then we get a sip of water. But thanks for your great presentation. We will send slides and a follow-up email to everybody after today's session. So if you were asking or wondering about that, they will be coming your way. Let's go to our first question that actually was submitted beforehand, and then we'll get to the Q&A portal. So this first question, I was thinking, Larry or Mark, you may have some things to say. The question is, how can cancer centers manage the anticipated influx of patients whose treatments we've delayed while all the ongoing restrictions regarding physical distancing continue to be warranted? Any thoughts, Larry or Mark?
Yeah, I mean, I can start with that if that's okay, Mark.
Sure.
So, I think one way to think about this is not an on-off switch. We're not going from where we are now to where we would be 4 months ago or 5 months ago. It's going to be a gradual increase. Am I echoing here?
Yeah, a little bit, Larry.
Just a little bit.
I don't know why, but let me just try to fix that. So, this is not going to be just an on-off type of thing. And one of the things that has struck us, because we've now started to scale back up again very slowly, is that not everybody wants to come in and be seen. We've offered people who have had delayed surgery the ability to come in and be operated on this week or next week. And I say, well, we're not that comfortable with that. We want to wait a little while longer. One of the things that I tell my faculty is think about what our waiting rooms in our clinics looked like in January. People were shoulder to shoulder, all the seats were taken, people were standing in the corners. We're not going to end up back in that spot. We can't afford to, which means that our volumes can't be what they were before. And we had a planning meeting this morning, as we do almost every morning, talking about the fact that we were going to have to learn what it took to have appropriate social distancing, appropriate clinic schedules. We were not going to regress completely from telemedicine, which is how we're doing a lot of our care. It was going to be a combination of more inpatient or in-person visits, but still retaining a lot of our telemedicine care, because our centers cannot work at the volume they were 4 or 5 months ago with the current risks of infection. So I think all of us need to figure that out. And then Mark, if you have other thoughts.
No, I think, Larry, that's correct. We're continuing to use telemedicine for a portion of our patients. I would say current estimate is about 20% of our visits are still telehealth visits. We're, of course, increasing the frequency of our testing. We're looking for those asymptomatic patients who might be carriers or pre-symptomatic. So that frequency is increasing. Of course, we're all doing, many of us have started doing serologies, and we're getting ready to roll out an approach to look, at least in our healthcare providers, how many patients or how many of our providers have been exposed, and not absolutely clear what that means in terms of immunity. But the other thing, it relates to the physical distancing. And, you know, one of the things we're considering right now is extending the hours of our clinic and putting fewer patients in each clinic. That would decompress our waiting rooms, which typically have been fairly crowded. It's the one way we think that we can continue social distancing is to extend hours till 8 or 8:30 in the evening and begin clinics at 7 or 7:30 in the morning. We haven't implemented this yet, but it is a possibility that we're considering.
The one other thing I would say is that factored into all this is a completely different ritual of cleaning the rooms between patient visits. In ways, of course, that we didn't do before. We used to just change the sheet on the exam table and put out a new gown, you know, and now things are getting scrubbed down, including the computer keyboards and the little modules that we use for patients to sign consents and so on and so forth. And that all obviously all takes time. I mean, there are a million little pieces to all of this.
Yeah, true. Definitely the details really matter in all of this. It's a really interesting thought, Mark, around extending your clinic hours. Let me ask one kind of follow-up question on that. As you all think about what that might look like, are you starting to think about what the workforce might look like and staggering the workforce, or any thoughts on that?
Yeah, I think that would mirror the clinic schedule. So the workforce would also have to be staggered in that model. Mm-hmm. Absolutely.
Yeah, for sure.
Yeah, I mean, we're going to put fewer providers, fewer physicians and nurses in the clinic at any given time. You know, they'll be doing remote telemedicine on Monday, and they'll be in clinic on Tuesday, and two teams will switch, you know, Monday and Tuesday, and so on. So yeah, we're all looking at that very carefully.
Mm-hmm.
And then Mark and Larry, how have you guys, since you guys are part of the hardest hit areas, how have you guys budgeted or accounted for potentially a portion of your workforce being out because they're sick, and then trying to reintegrate that? How have you guys done that in terms of planning purposes?
You want to go first, Mark, or you want me to? Well, happily, you know, not a great number of our workforce has been sick, at least if you're implying that it's related to COVID-19. Very, very small percent have actually been infected, and hopefully that's because we've emphasized a lot of preventative measures. And our staff have been very, very aware of not only their own risk, but if they become infected, what that means in terms of risk to patients. So right now, that hasn't been much of a problem. Of course, the whole COVID-19 problem and volume changes has impacted our budget very, very significantly.
I mean, at the very beginning, we had some groups who were exposed and needed to be quarantined and had some substantial gaps in our staffing, not just with direct patient providers, but other staff as well. And I think since we've been more careful about reducing the number of staff on site at any given time, and being more careful and having more protective personal protective equipment, we've also done pretty well. So we haven't had large groups of staff out.
That's great. Glad to hear that in both cases that we're not seeing huge numbers of staff. I know there's still a risk and things to plan for in that. Let's go back up just a little bit and think about some of what you spoke to, Tom, in the didactic about, where we are and what maybe, different phases of the new normal, I'll say, as we are beyond the, immediate acute phase of this pandemic. And as we're starting to see populations and states, with reopenings, what are your recommendations for everybody about how individuals should handle the early reopenings happening across the country? That would be. Go ahead.
Yeah, I think that it's something where some of the preventive measures ideally should still be in place. I mean, especially for our cancer patients. I mean, I think there's no question that they should be wearing a mask out at all times out in public, washing their hands frequently, doing the social distancing. When our cancer patients get sick, really trying to think about what their world would look like in quarantine. Who's the dedicated caregiver, or who's the person who could potentially help them out with those type of things. I think we really have to take care of that as well. My biggest worry is seeing all those things where you start seeing beaches open and all of a sudden thousands of people just clamoring all over each other, and you're thinking about what the potential is in terms of outbreaks. I mean, we saw, on that U.S. naval warship, a huge outbreak because of close proximity. You saw on the Diamond, Princess, cruise ship, same thing. A lot of people in close proximity, and if one of them gets sick, there's a lot of people who get sick. That's the worry. And how do you try to envision or plan for a world like that? And so, will we, all of us, next year this time, still be wearing a mask from time to time? We honestly don't know. But I think those are the things that we have to kind of anticipate as we go. I don't know what normal is anymore. I mean, it's just every single day is kind of, you're just trying to navigate things. But it'd be interesting to see what Larry and Mark say as well. I mean, but I think that's the world that we're navigating right now going forward.
Yeah, I think a month or so ago, maybe longer, people were saying, oh, after this, we'll have a new normal, we'll do things a little bit differently. But I think what they were imagining in their head would be COVID is gone. We do things differently. We have a different normal. And I think now people are starting to think about the fact that maybe COVID's not going to be gone, and that there may be second waves. But even if there aren't second waves, we're going to have persistent infection for a while, and we may open up some, but our lives will be very different, and the lives for our patients will be very different.
Yeah, I agree. I think we probably have a lot of people who are recognizing that more and more each day. Yeah, things are changing so much, and definitely not anything that anybody anticipated to this degree, I don't think. Let's shift gears a little bit. I'm sensitive to our time, and I do want to get to this topic of cancer screening, and we've gotten some questions in on that. So here's our first question. One question was specifically for you, Dr. Varghese, since you spoke a little bit about your operations in your university setting and academic setting. What have your center's discussions been about opening up routine cancer screening, and when do you anticipate that, and any key considerations around that topic?
Yeah, so we're working closely with all of our screening. So our screening doesn't just occur here in the state of Utah. Our catchment area is like the 1,200-mile Intermountain West region. So we are actively talking to all these different centers about restarting the community, the screening. We have to do it because, again, the fear right now that all of us have, it's kind of what both Larry and Mark alluded to, is that are there patients out there with cancer that are so scared to come in that, they're just having undiagnosed cancers that are growing in size and potentially spreading. I mean, that's our fear. I mean, you saw those numbers from that EPIC study of just the number of community screenings have plummeted. And I think what we have to do is figure out the way, we have to do it. We just have to figure out the way to do it safely. And I think part of it is at all these different sites, again, restricted visitor policies, masking, temperature screening, all the different things that we're doing at the main centers, we'll probably be doing there at the local centers as well to do that. But we have to do it because you know, you can imagine there may be studies going forward. The American Cancer Society, the NCCN may be doing these studies. All the gains that we just made in the last 30 years, are they all going to start getting undone now as a result of this? We don't know, but we have to do it. We just have to figure out the details and how to do it safely.
Mm-hmm. Yeah, great points. You know, there's the population of people that are, you know, up to date with their screenings and have had regular screenings and are average risk with no new symptoms. Maybe a couple month delay won't be, you know, such a big deal.
The only other thing I would add to that is, I think somebody had mentioned before, the impact of losing your job and the lack of insurance.
Mm-hmm.
I mean, we have millions of people who've lost their jobs as a result of this. Now, if they have no health insurance, you know, how do you navigate that? I mean, we have a lot of work to do as a community.
Yeah.
I think so.
Yeah, I mean, I've had patients who, no, it's just because I've had patients who have lost their job and their insurance will run out in 30 or 60 days and they want their screening exams before their insurance runs out. So it is a complex dynamic. The other thing we worry about is the health system. You know, if it were my wife, I wouldn't necessarily want her to come and get a mammogram in 2 weeks, which is when we're going to open up our mammography screening program again. On the other hand, we worry about being more months behind and then trying to catch up with the backlog, and how are we going to manage that backlog? So there's just a lot of things to weigh in here.
Mm-hmm, certainly. And then we think about, you know, there's varying levels of risk and who may have family history or a history of an abnormal screening test that needed follow-up right when the pandemic started. How are you all handling that within your centers of starting to understand who to call back first or how to deal with the recall of screening tests that need to be done?
So, I mean, I can make a brief comment about that. So we tried to write out some guidelines for this, but it turns out for many reasons, it's very complicated. You've mentioned some of them. You may have a woman who's got a family history, but has had germline testing that's negative, or one that has germline testing that's positive, somebody who's 40 years old versus somebody who's 75, who you're more worried about bringing in and potentially getting infected, because age is a clear risk factor for serious and fatal complications from COVID. You know, so there are just a lot of degrees of risk here. And so our conclusion was, yeah, we can have general guidelines, but in the end, it's a conversation between a provider and the patient, and trying to weigh risks and benefits for each individual.
Yep, good, all well taken points. I think there's very many complexities to these discussions, and engaging, you know, in the primary care space all around, like preventive care, kind of generally ramping back up at some point, will probably be a big part of helping with those conversations for a good part of the population as well. I don't know, Mark, did you have anything you wanted to add on the cancer screening topic and when and how to restart screening?
No, I think Larry's comments about individualizing this with the patient and the physician are great guides. So nothing.
Yeah. Agreed. Yeah, great. Thank you. I'm going to shift gears. The screening topic we could do, and we will, I think, continue to address this as we look forward, as we move forward together and be able to do more sessions on even just that topic. I think there's so much there. I don't mean to, you know, take a very complex topic down to about 5 minutes of discussion, but just recognize that there's, you know, multiple layers to this. We are really just, I think, as a country, starting to figure out how do we safely reopen where we can, and how do we safely get back to some of our other healthcare needs outside of the acute needs of COVID. So I'm going to just pause that conversation and then go back to a question we had that was in the pre-registration around the impact of COVID on COC accreditation, Commission on Cancer Accreditation. So while we have Larry on the line and some of our other COC and NCCN experts, I wanted to address that.
Sure, Laura. You know, as you mentioned at the beginning, I'm the chair of the Commission on Cancer, and we've already spent an uncountable number of hours trying to answer this question for you. And we've put out general guidance, which I hope you've seen. We want all of our centers to concentrate on providing cancer care in the context of COVID. not in the context of what our standards were and our requirements were previously. The timing is a little funny. As all of you who are Commission on Cancer accredited sites know, we spent about a year formulating a whole new set of standards, which became active in January of this year. And, 3 months later, we're in the middle of a pandemic where the relevance for a lot of that has obviously shifted. So my advice to you is, like we're all doing in our centers, it's COVID morning, afternoon, and evening, and all night long, and we're trying to figure out how to get through the pandemic, and that should be your primary concern. And the usual things that we hold programs accountable for in the standards, obviously a lot of it's just good cancer practice, but the documentation and the specific requirements are all going to be waived during the pandemic. We've also delayed accreditation site visits for at least 6 months, if not longer than that. I think all of us, it goes with the conversation we've been having for the last hour. None of us know quite how this is going to play out. And there'll be more guidance coming in the next months. But right now, we want you to provide as good a cancer care as you can for your patients in the context of what the pandemic is like in your own institution. And we'll figure out the other specifics as we go forward. It's going to be a very unusual time, but we all have the same goals.
Great, thank you. I suspect many of our audience members appreciate that and appreciate hearing from you on that topic. And thank you for your sensitivity and understanding of where we are with the pandemic. I'm looking at our time. We're just about to the top of the hour. I don't know, Tom or Mark, do you have any last closing comments you'd like to include?
I think that the biggest thing is all of us are navigating this world together. And I think I want to emphasize the word together. Really, this is probably the best opportunity to figure out, not only look at content experts within your own institution, but really reach out. I think that if there's a positive that may come out of this, would be hopefully to strengthen collaborations and coordination of care between different centers. One of the things that we've been incredibly blessed with over here at the Huntsman has been the great resources and help from centers like Larry's over at Penn and Mark's over in Seattle in terms of just learning from their journey and easily sharing those resources. And so I think if you're in the community or at an academic, wherever you are, I would say that really reach out and make sure that you don't try to navigate this by yourself.
That's great. Thank you so much. We really are, I think that's such a good comments to end on, and recognize that we truly are better together. I think we are better together and in our communities, in our institutions, and certainly it's going to take all of us together to figure this out, to take care of people, to keep people safe, and come out of all of it stronger. So appreciate the time today. We will be following up with an email with some of the slides and some links to some resources that were mentioned during the presentation. I'll just hand it over to Rich to wrap us up, and we will say goodbye for now.
Awesome. Thanks, Laura, and thanks to our panelists. This has been, this is the final of the 3 sessions, and this has just been a great experience. I can say I've learned a lot. I've seen some of the feedback that's come back as well. People generally seem to be very appreciative of the information that you all have shared, so thank you for that. That said, to all of our attendees today, you will receive an email later this week that'll include some recordings and slides used for this session. It'll also include some recordings and slides and resources from the previous sessions as well. So look out for that, an email from the American Cancer Society ECHO office before the end of the week. Please, just because this is the last session, please do continue to complete the post-session evaluation. We want to know how this series went, this series of 3 sessions went, but the feedback that you share with us will also help us craft future offerings. And on that note, look out for future offerings from the American Cancer Society and NCCN in the summer about how COVID-19, how the pandemic impacts cancer and intersects with cancer. And if you have any questions in the meantime, please don't hesitate to reach out to echo@cancer.org. So we're at the top of the hour. Thank you everybody for joining both today and the entire series. Thank you again to our panelists. Thank you so much and have a great and wonderful day. Take care all.
Thank you.
Thank you all.
All right.